everyone. Thanks for having me. I'll be presenting work that I've been doing with Julia Adler-Milstein, my advisor, and some colleagues of ours at Blue Cross Blue Shield of Michigan, looking at the effect of electronic health records on patient costs in patient-centered medical homes. So lots of use of the word patient, which I heard yesterday is a good thing. So I'm really glad we had a wonderful talk this morning talking about some of the value problems that we have in the U.S. healthcare system, so I won't go into that. But one of the proposed solutions to address some of these issues of high costs and insufficient quality is the patient-centered medical home. Now, the PCMH has had a long history in the United States, but it was really revitalized by the Affordable Care Act. The PCMH is a very lofty goal. It has a number of principles that have been endorsed by major primary care associations, which I list here. And as you can see, these are really aims that are meant to address both the cost and the quality issues that we have in the United States. So when you're providing care that is more continuous, that's more coordinated, in theory that should lower costs and increase quality. In addition, there are a lot of benefits to providing coordinated, comprehensive, compassionate, etc. So the other thing I'll point out is that these are some very large principles, and you're not going to find a patient-centered medical home that's simultaneously embodying 100% of all of these goals. So we really think of the patient-centered medical home as a transformation. It's not a 0-1 state. One of the practical ramifications of this is that you'll hear me use some very technical words today describing practices as being PCMHE or PCMHER, or being very high on the PCMH-ness scale. So presenting this work today because we're focusing on the role that electronic health records can play in patient-centered medical home success. Electronic health records can support patient-centered medical home achievement and patient-centered medical home success in a number of ways. So you can think about how electronic health records work with task tracking and how providing more information to providers about who's supposed to be doing what for their patients can really help embody some of these principles on the previous slide in terms of providing continuous care and comprehensive care. Likewise, when you have more patient-level data, you can really see some of the benefits that you might find from using electronic health records to support patient-centered medical home work. However, as we've also heard in a number of sessions today, research indicates that electronic health records might not be up to this task currently, that they're too focused on billing, that they're not dynamic enough to meet patient-centered medical home demands. And so it's actually a little bit curious whether or not electronic health records would end up increasing the costs of care rather than helping patient-centered medical homes in cost reduction. So that's really the motivation for the study. We're looking at the effect that electronic health records have on the relationship between patient-centered medical homes and cost savings. So I'm an organization studies person. We would call this a moderation model, really trying to look at the effect that this new variable of electronic health records has on the more direct relationship between patient-centered medical homes and cost savings. We conduct this work in Michigan using practices that are participating in a very large payer's pay-for-performance program. So Blue Cross Blue Shield of Michigan is the dominant payer in Michigan, and they have a voluntary pay-for-performance program that's been going on for almost 10 years and has large participation across the state. A cornerstone of this pay-for-performance program is the patient-centered medical home program, which is similar to other programs that are being advanced nationally. The Blue Cross Patient-Centered Medical Home Program focuses on 9 domains. So you can see here that includes things like extended access, preventive services, a lot of different ways to operationalize those principles that we discussed earlier. This is then further broken down into capabilities. So under the 9 patient-centered medical home domains, you'll find varying numbers of specific objectives that practices need to meet. So as you can see here for test tracking and follow-up, instead of just having this checkbox, yes, I'm tracking tests and following up with patients, there has to be a systematic approach to inform patients about abnormal test results. The practices have to have a documented process and procedure. If you're reading ahead on slides like I always do, you may be a little bit concerned that the very last capability requires that practices use health information technology, in that it says that practices have to be doing computerized order entry system. And we address that in our model. We don't want to have IT on both the right and left-hand side of the equation. So what we do when we operationalize this concept is exclude capabilities that require IT. But I'm getting a little ahead of myself. So I'm sorry, our data source comes from practices self-reporting PCMH and Health IT capabilities to Blue Cross Blue Shield of Massachusetts. So every 6 months they fill out a form, they tell Blue Cross, I've got I'm doing capability 6.1 and 6.5, I'm not doing capability 6.3. And this data is audited by Blue Cross every 6 months, so we have a fair amount of confidence in its accuracy. The data provides us our two key independent variables. The first is this measure of PCMHness. So we take all of the 9 domains and all of the 114 capabilities. We exclude those capabilities that explicitly require information technology, and then we assign practices points for achieving the capabilities. And every capability gets assigned 1 point, and every domain is weighted equally. This is a model that others using this data set have used. There are other ways you could think about measuring PCMHness, but this really provides a very basic descriptive and non-normative way of saying that certain capabilities are more important than others. The other data that we have from the source describes practices' health information technology adoption. So it's a binary measure. I wish we had richer sources of the extent to which practices were actually using the technology, but we do have a yes-no for several periods of time about whether or not practices have self-reported electronic health records, which is our focal IT characteristics, and then we also have controls for other types of information technology, registries, electronic prescribing, and the like. We have other variables from Blue Cross. Very exciting. We have BCBS's enrollment and claims data. So we're able to pull together practice-level cost measures using average total medical and surgical allowed costs per member per month. So our patient costs estimate is, we're very confident in the accuracy because it's what Blue Cross uses to actually pay the providers. And it covers the range of inpatient and outpatient services that patients are receiving. It doesn't get at medication, but we're really getting a lot at what doctors are billing Blue Cross for doing to Blue Cross's patients. We're also able to use this data to construct a number of practice-level controls. So this includes an example of size, the number of Blue Cross patients, and turnover. And then we also bring in data from the census and the American Community Survey to get at market-level characteristics, such as Blue Cross's share of patients in that particular area, percent unemployment, things that might affect patients' healthcare utilization. So just some brief descriptive characteristics about our sample. You can see here that a lot of them are small practices, not small in stature, and that electronic health record adoption and costs both increase over time, as does practices' average score on the patient-centered medical home NIS scale. Our analytic approach is to use multivariable, cross-classified linear mixed models. And this estimation strategy accounts for the longitudinal nature of our model, and it also accounts for some imperfect nesting that we have with practices. So because they're clustered, and they're clustered in different ways over time. We include a random effect for practice because although we believe that the variables in our model will likely affect practices in a similar way, they are likely beginning at a different place, and so the random effect really helps us net out some of the unobserved heterogeneity in our sample. And our main variables of interest are electronic health record adoption status, degree of PCMH transformation, and the interaction term, which really speaks to the moderating nature of the relationship. We run our models in 2 different ways. The first lags the variables by 6 months relative to PM costs, and the reason for this is that we believe that electronic health record adoption may take some time to really demonstrate benefits and cost reduction. So we measure cost over a 1-year period beginning 6 months after our very first EHR, PCMH measure, et cetera, and then we also run the models concurrently. So tables, we have a lot of controls that are on secret later slides if you'd like to see them, but you can see the main effects here. So 2 of our 3 main independent variables are significant, the first being the effect of electronic health records on patient costs, and the second being the interaction between electronic health records and PCMHness, the former having a significant positive effect on costs, positive being negative in this context in the sense that it's a cost increase, and the latter having a better effect in terms of decreasing costs. I like pictures, so I'm going to show one now. These are the predictive margins demonstrating the separate effects for electronic health records and for practices, that have electronic health records as they increase PCMH adoption. So you can see the darker line with triangles at the top has a downward trend, which indicates that practices with electronic health records have decreasing costs as they increase their PCMHiness. On the other hand, practices without electronic health records experience increasing costs as their PCMHness increases. The other thing I'll point out is that the lines intersect at a relatively high point on the PCMH score, and so you don't really see this crossover, this benefit from combining electronic health records and patient-centered medical homeness until you're relatively high on the PCMH domain. So that's where our analysis is right now. I think that there are some pretty interesting findings there. First being that EHRs are associated with higher PM costs. That's the direct effect of EHRs in the model. And trying to think about why electronic health records would increase patient costs, one of the hypotheses that we came up with that, I warn you, we can't test, has to deal with unmet need in terms of electronic health records helping to identify services that patients aren't receiving that maybe are increasing the cost that Blue Cross is receiving. And just to hedge off some potential questions, again, this is a cost measure that's based on patient services, and it's not based on the actual practice expenditures in adopting and acquiring the technology. The second interesting set of findings deals with this moderating relationship, so the fact that EHRs are associated with reduced costs as PCMH increases. And this is really, I think, at the heart of the paper in terms of why electronic health records help PCMH activities reduce costs for patients and probably reducing the services that they're receiving or shifting services from an inpatient setting to an outpatient setting, which would be more cost efficient. So we think that this may have something to do perhaps with referral tracking for high-risk patients, so that electronic health records are helping practices follow up on specialty referrals. Patients might then not be receiving as much care in the specialty setting if the care can be managed back in the primary care domain. Also that there may just be improved delivery of preventive care. So when you have electronic health records helping practices come together, helping them track data, helping them track tasks and figure out more clearly who in the practices is actually providing the services to patients and who's supposed to be doing the follow-up, that there are some real complementarities there between the workflow PCMH processes and the functionalities that electronic health records can bring to the table. A number of limitations. So first, this is observational data, and it's also self-reported. There is a lot that we can't control for. This isn't an experiment, so there are a lot of confounding factors that we weren't able to address in our model, despite our attempt to throw in every variable we could get our hands on, including practice-level effects. We can't look at the actual workflow changes to see what may be going on. Likewise, our data only capture electronic health record adoption and not use. And so the hypotheses that I proposed about why we might be seeing these effects, we're not really able to tell if practices are seeing improvements because they are using more task tracking rather than others. And finally, we only have 1 year of data post-adoption, although we've been working on this analysis for so long that we may have more data coming our way, so hopefully we can extend these findings. I would also like to say, though, that there is an incentive for practices to over-report their PCMH attainment because they get paid for it, and so to the extent that the bias goes in the direction of diluting our findings, we're a little mollified by the fact that we were able to find something in our models. So, this is where we're at. I think it's pretty exciting. Electronic health records appear to be helping patient-centered medical homes achieve cost savings, which is great because private and federal funders are putting a lot of money to incentivize both the adoption of electronic health records and the adoption of patient-centered medical home traits, attributes, and so it's really promising to see that money might not be going to waste. However, practices that chose to adopt EHRs were higher cost at the outset, so that may be interacting with our findings in some way. We're really hoping to find other data sets, maybe do some qualitative work to examine these mechanisms to see if it really is the case that we're witnessing cost savings due to referral tracking, improved delivery of preventive care, or a number of other complementary EHR plus PCMH services that might be improving the efficiency with which patients are receiving care. So I have 39 seconds, but I think I'll cede that because my discussant indicated that he had a lot of fun things to say. So thank you.
All right, our discussant is Lorenz Helkman from George Mason University, who tells me he's a perennial white discussant, so that means he must have done a really good job the first 4 times. So looking forward to this. All right.
Thanks, Chad, for chairing the sessions and for the kind introduction. And I want to thank the organizers. This is indeed the 5th time that I'm here. I see some technological innovation because we have this beautiful display of how much time is remaining. I could see some wearable devices that jolt discussions whenever they're not nice. So I'm looking forward to the next 5 conferences. Fall wouldn't be the same in Washington, D.C. without the White Conference. So, yeah, that's just to get me in next year. So let me just recapitulate the question. Does EHR adoption moderate the relationship between the degree of PCMH transformation and the cost of care for patients treated by PCMH practices? As Jenna just said, the main finding here is that if you don't have an EHR, you experience a slight increase in your cost per member per month, at least as you go from zero transformation score to 100. Okay, so that's a pretty big leap. And if you do have an EHR, that moderates it in the sense that costs are declining. So you start off with a higher level and then it declines. So I want to focus on 3 questions. The first will be, is there any way we can improve the claim or the suggestion that this might be causal? The second is there any way we can make headway to elucidate a little more about the mechanism that was at work in bringing about these results? And third, was it worth it? So let's start with the first question, was it causal? So as Jenna mentioned, there is probably some unobserved heterogeneity, but just remember the random effects model is a weighted average of the within estimator and the between estimator. So you're basically getting sources from these 2 kinds of variation. So of course then a simpler way would simply be to put in practice fixed effects, and that really gets rid of any time invariant unobserved heterogeneity. And if you also cluster for the standard errors, then you have a pretty clean estimate in that regard. Because it is probably the case that early adopters are not the same as late adopters of EHRs. You could, if you did that, you would be tracking the middle of the pack adopters, right? So the adoption rates went up from 43% at the beginning of the study period to about 61%, so there's an 18 percentage point increase. But you didn't get the early adopters and you're not getting the late adopters here. So that would be also something to keep in mind. But if you had adoption dates, I'm not sure you can obtain these, then you could do a much richer analysis and could put these in and have practice-specific dummies, essentially, when they were adopting the technology, the EHR. It's also possible that there are pre-existing time trends in cost. And although you seem to just use 2 time periods before and after, I was wondering if it wouldn't be possible to use patient quarters. If you have the data at a level that's disaggregated in this way, then it would be fairly straightforward to add a time trend to the model, interact it with a PCMH score, and test for a trend break at the time of EHR adoption. You could also look at, or probably consider the contemporaneous adoption of other health IT components, such as patient registries, e-prescribing, and personal health records that you mentioned in the paper and your slides. So the only worry here would be that since these were also contemporaneous, we see a lot of collinearity between those 4 technologies, those 4 IT components, to see if there's any information on or any source of variation in the adoption decision of EHR that's orthogonal to these other technologies, because you're always worried that, if even on the observables you see so much collinearity, what else was changing in the background? One thing that may have been changing in the background, actually you acknowledge that in your slides, is that this was part of a pay-for-performance program. So I was wondering if there are any non-PCMH and non-EHR incentives to lower costs that were associated, that were operating at the same time period. So what was the mechanism? So basically the template here would be simply to disaggregate and try to drill down into the specific cost components that you might have. So one, of course, would be those cost components that should respond to PCMH. Could be avoidable hospital stays, ED visits, specialist referrals. Here it would be valuable if you could relate those results to findings from existing studies and maybe even replicate that so we know what the baseline is and how generalizable the findings are. And you could also look at the cost components that should respond to EHR. See, my time's up, so I'm getting the jolt right now. So we heard earlier today, that billing for previously undocumented services may have gone up. So if you could relate that too, that would be great. The cost components that should respond to EHR, maybe you can identify specific ones, and you've mentioned a couple, such as duplication of tests, maybe readmissions. So it would be valuable to see how they responded. And then exploit the fact that practices increase their transformation score on certain dimensions, maybe not on others. There are specific patient populations that should be much more susceptible to this intervention, such as those with multiple chronic conditions. And then maybe do a placebo test. So try to identify procedures that should not have budged at all, such as emergent appendectomies, right? They're not beyond the control of the primary care practices. Okay, was it worth it? Maybe expand a little bit on the practical significance of these cost savings, right? The practices didn't go from 0 to 100. They went from 54 to 57% of the possible score. So were these on average, were practices just adding like one component, or were there a few practices that were adding the whole complement of PCMH features? And you also have EHR adoption that increased not from 0 to 100, but somewhere in the middle. So it would be valuable to kind of get more realistic assessment here. And then obviously EHR adoption is not cost-free, nor is PCMH transformation. The payer was running a pay-for-performance program, so you should probably, it would be interesting to see how much they paid for this whole thing. And then also, ultimately, health outcomes, did they improve or not? So cost is one dimension, but as you mentioned in the introduction, the value equation includes improved health. So that's it from me.
Good morning, everyone. I'm Yiqing Lin, a PhD candidate from Carnegie Mellon University. It is my pleasure to present one of my research, RFID-enabled analysis of care coordination in ambulatory care. Healthcare is primarily delivered in the ambulatory care setting. However, the high variability in this environment negatively impacts process efficiency. So generally, usually a patient starts their visit from checking in and then staying in the waiting room and staying in the exam room and then finally check out. However, due to privacy issues, what's going on in this exam room is usually like a black box. So many of the studies could only focus on the patient waiting time in the waiting room. However, in reality, patients spend a lot of time waiting in the exam room as well. In our previous study, we were able to break the black box, and then we found that patient scheduling, a different patient scheduling, a common approach used by studies to improve the process efficiency can only reduce the waiting time in the waiting room, but not the waiting time in the exam room. Care coordination has been regarded as a key to improve process efficiency. So we believe that it has something to do with the care coordination, with the waiting time in the exam room, where multiple clinicians deliver care collaboratively. Technology is evolving rapidly. Because of its ability to unobtrusively collect data at all times, NIH has encouraged studies on smart and connected health. Studies have shown that by leveraging potential of healthcare information technologies, patient care can be improved, cost can be decreased. The challenges faced by our studies are two. The first is there's no good data for modeling the flow of patients and clinicians. The second is there are no best practices for care coordination delivery sequences. For care delivery sequences. However, we also see our opportunities. The first is radio frequency identification. This is the chip which can track the movement of any object or human being. So this technology can collect data unobtrusively and precisely. With the availability of this data, we are able to use Markov decision process. This is a model generally used by studies for treatment planning. So this is a model. So we can use this model to find the best practices for care delivery sequences. So our research problem is to develop care coordination policies in the ambulatory care environment that minimize patient waiting time. Specifically, we want to know how can care coordination be modeled and what is the best delivery sequence to improve performance. So by using a novel IT-enabled point-of-care data collection method, we developed generalizable analytical models for care coordination. Our study site is a specialty clinic affiliated with a major academic medical center. We have 6 physicians, 1 physician assistant, and 3 medical assistants. We have RFID monitors installed in each room of our clinic. Tags were worn by patients and clinicians. 1 monitor in the room will scan its territory every 6 seconds. So whenever a tag is detected by the monitor, the communication between the tag and the monitor will generate time and location stamp data. In addition, I also did some observations and interviews in the clinic. So this is the layout. The black bar on the left, that is the entrance of the clinic. And then we have check-in and check-out rooms. We have waiting room. We have occupational therapy room and procedure room. We also have 7 exam rooms. So the red dots are the monitors, but only the data collected by the 7 monitors in the exam rooms will be used for my study. Okay, this is a snapshot of the data collected by the RFID technology for 1 visit. So just focus on the red box. So we can see that outside. So here, each row is 1 read of the monitor. And we have data on the date, appointment time, and tag ID for each individual, and room ID for each location, and finally timestamps. So so encountering time with clinicians is defined as the time span when the clinician and the patient were both in the same location at the same time. So for example, we can see the 3rd row. The patient number 2283 enters the exam room 165 at 9:03. 2 minutes later, a medical assistant joins the patient and then stays there for 18 minutes. 5 minutes later, a doctor comes in. And 3 minutes later, a MA comes in and joins the doctor again when the doctor was still there, because the doctor was still there until 43. And 12 minutes later, the doctor left the room, leaving the medical assistant and the patient staying in the room alone. And 7 minutes later, the medical assistant also left the room, which also concludes the encounter. So after this, we transformed these records to a sequence of letters to represent 1 visit. So for example, in the bottom graph, we see the sequence EMEDJMY says that the patient first waits in the exam room, and then sees an MA, and then waits again, and then sees a doctor, and then sees a doctor and an MA together, and then sees a MA, and finally Y is a dress up. So we collected data on 19 business days. In total, we have 389 visits made by 327 unique patients. Among the 204 complete visits, we found that there are 90 unique encounter patterns. This is a huge variation in such a clinic with homogeneous service. For example, MD 6 and 8 are 2 major physicians in our clinic, but MD 8 usually initiates the encounters by himself, but MD 6 usually sends an MA to initiate the encounters. This is the performance at status quo. I have time distribution for each physician and also for all physicians. So in the in the most right bar, we can see that on average, patients spend 40 minutes in the exam room, and of which 19 minutes were for waiting for a clinician, and only 8 minutes were for seeing a doctor. Sorry, it's hard to read. But the main point is that the patients spend a lot of time waiting in the exam room. And if we look at the variation across different physicians, like physician MD6 and MD8, these two physicians, they have similar workload, but they use different policies to initiate their encounters. And then we see that they have significant different patient waiting time. To model the sequence of care coordination, I use Markov decision process. It is an analytical model to find the best policy in a discrete time dynamic system when the outcome is uncertain. Following, I will explain to you how I formulate each of the 4 elements in my MDP model: states, decisions at each step, transition probabilities at each step, and cost at each step. So I have states 2 to n to represent the encounter activities between patient and the clinician. So for example, state number 2, MD, this is the encountering activity with a physician. State number 3 is the encountering activity with a physician and a medical assistant together. I also have one starting node, 0, and terminating node, 1, to the right, and then which is also the absorbing state. Transition probabilities, Pij, is a probability that the patient will meet with clinician set J at the next stage, given the patient is meeting with clinician set I at the current stage. So for example, after the patient entered the room at the first stage, the patient might see a MA at the next stage 50% of the time, but the patient may also see stage 3, the doctor and 1 MA at stage 2 for 50% of the time. The purpose of the study is to find who should provide the service, the first, the second, etc. So there is one decision to be made at each stage, and the decision will be the transition probability. For example, a clinic manager might say, let's try to send a medical assistant to initiate encounters at all times. This could be the decision for the first stage. Cost will be the mean patient waiting time between each pair of the states in each stage. For example, the patient, after entering the room in stage 1, the patient might need to wait for 1 minute for seeing a MA, or wait for 10 minutes to see stage 3 to see a MD and 1 MA. So a policy is a collection of all decisions made at each stage, and the total cost will be the sum of the cost incurred in each step. Transition probabilities at each stage are observed from our data. In today's talk, I will just focus on the decision to be made at the first stage by trying some arbitrary decisions. The goal is to find the best policy which results in the minimum patient waiting time. The cost at each step is actually just the sum, the weighted sum of the waiting time. So here, so it is the sum of the waiting time for each possible transition weighted by its transition probability. So let's use the data for MDP as an example. There is a 46% of chance that a patient will see a physician at stage 2, which requires about 25 minutes of waiting time on average. So the expected waiting time at step 1 will just be the weighted sum of all these waiting times for different encounter activities. For step 2, the waiting time for seeing a physician in stage 3 will be also the weighted sum of all waiting times transitioning from different encounter activities. So we use the same calculation to calculate waiting time for other states as well. And then the total expected waiting time for step 2 will, again, the weighted sum of all the sum of all waiting time for each possible encounter activity weighted by their transition probability. Similarly, we have the same calculation for step 3, 4, 5, 6, 7, and finally, the process converges at stage 9. And then the average patient waiting time we calculated from the MDP model is 21 minutes, which is also the same as our observed data. These are some results for MD6. So the best policy which can have the least patient waiting time would be the Pi1, which sends 1 MA to initiate the encounters 66% of the time. These are the results for MD8. So at status quo, MD8 usually initiates his encounters 46% of the time by himself. However, if we send a MA instead of the MD himself, then the patient waiting time can be reduced from 21 minutes to 10 minutes. So this study confirms that there is a substantial variability and lack of care coordination in ambulatory care delivery. RFID technology is great at collecting data. However, it has limitations. The biggest one is it may result in missing data. A guideline provided by MDP model can reduce process variability and patient waiting time while still allowing special treatments for some patients. Future studies include using MDP model to examine more policies in all stages by using different cost functions. So today, this is just an illustration about the care coordination analysis in one clinic. However, this approach can be generalized to broader environment. For example, we can analyze the best care coordination sequences among different specialty offices for patients with multiple chronic diseases, which is also the ultimate goal of my research. Acknowledgements to UPMC, the study site, Centrac, the RFID vendor, and Dr. Zheng, Dr. Hampshire, and Dr. Biller for their feedback and guidance on my data analysis. And finally, thank you very much.
Good morning, everyone. It's my first time to the WIDE conference. It's such a small but beautiful conference. Okay, I enjoy being here. Okay, my name is Ting Long Day, and I'm an assistant professor at Johns Hopkins Carey Business School. I was originally actually from the same school as Yichen, so I studied at Taipei School, so she studied at Heinz School. And interestingly, back to 2008, I did almost the same kind of study as she did. So we had the same, so I did study at the UPMC Eye Center. So she didn't mention the name. She said there's one major academic medical center, so which is UPMC for sure, right? So, okay, so both of us worked at UPMC around the same time. Both of us collected patient, physician interaction process data. So I use a videotape. So I videotaped the UPMC Eye Center for 12 days. And I captured about more than 300 patients and more than 500 sessions. So that part was easy, but the coding took me half a year. So it took me half a year to just get the raw data. I assume it took a shorter time for each chain to get raw data, but maybe a little bit more to do the subsequent analysis, because we didn't have any missing data issue. We have everything. We have every movement in the room, just that it took time to get them, right? So in that aspect, I really like the paper for its research design. So I wish I had known RFID. I wish when I did that research. So that's the reason I actually didn't finish that paper. So it motivated my job market paper, but it didn't become a paper. So I really admire Yichen for just completing this work, because it's extremely painful and tough. Believe me, it's very, very painful. And that's feature number one I liked. Feature number two, which is the MDP model. So I'm a big fan of MDP. So my master thesis was MDP model applied to inventory systems. So I'm big fan of her paper, right? So the motivation here, you have a nearly homogeneous service, but then you have 90 unique patterns, right? So MDP seems to be really natural modeling choice. And from the way she framed this problem and the way she modeled this problem, I see this really nice application of the classical problem of a stochastic shortest path problem. So it's a nice application. But then I have to say something about the limitation of this paper. So first of all, I was a little bit confused about the positioning of the paper. So what is really the key message of the paper? I think what do you expect the audience to remember from your talk? I think that's one thing you need to address. The other thing is that because you talk about the source of variability, so but from reading the abstract, I didn't really get that part. So is there anything surprising or interesting? Because you actually you did more than I think anybody else in the world has done, right, for the process analysis. So I would expect something really surprising, really interesting from the data analysis. And also, you talk about, in the ideal world, how the sequencing decisions should be made. I would be interested in knowing how the current decisions are made, right? So, what are they thinking when they decide to, always start with MD, always start with MA? There must be some kind of institutional decision-making process. And finally, how do you position your paper with the healthcare operations literature? Because that's the world that I'm from. So I'm interested in know how do we reconcile our differences, right? So second aspect is the practical concerns. So the first one is actually not really practical. It says to have any structure, analytical properties. The reason I say that is if you have any structure or property, that's where hopefully you can actually talk that to managers, right, to doctors. Because doctors, we all know that doctors are very special people, right? You cannot tell them what to do. You cannot tell them that, see, I have this MDP, so just do what the MDP tells you, which is impossible, right? So you need to tell them some solid insights from your work that they would like to hear, right? And also, the concern here is to minimize patient waiting time. So what about the doctors and nurses and those clinicians' waiting times? And you talk about the preference. And also, I think that one thing missing here is that patients have a preference, some preferences, and the doctors also have some preferences. I think somehow if you get to that part, that would be really helpful. Okay, that's my discussions. Thank you.
Okay, so I'll be presenting the last paper. And even though we don't have a discussant, I had a chance to talk with Carolina last week a little bit. I can just convey what she said. She said it was the best paper she's ever read. It would be criminal to change a word of it. Anyway, so this is a paper about the impact of clinical information availability on pregnancy care. And we have an army of co-authors here, in part because, or mostly because this was data that was primary data collection done over a 4.5-year period. So great colleagues from Lehigh University, the Lehigh Valley Health Network, and a former PhD student now at the University of Pennsylvania. I'd also like to acknowledge financial support for this research from the Agency for Healthcare Research and Quality, from the HIT portfolio, and from Lehigh University. So what motivated this was a discussion we had almost 7 years ago now when we were looking at the informatics literature on EHRs, and we saw that most of the studies, or almost all the studies, they're evaluating EHR systems, and some of them would evaluate how good those systems were at transmitting information. But there didn't seem to be any studies that looked at what the value of that information was on health outcomes, which is really something you'd want to know to justify large expenditures on EHRs. Because if you think about it, there's EHRs that are really providing, for the most part, historical information on the patient. There's information providers have when they're giving the care, the patient's in front of them. They can ask the patient things, and they also can conduct tests. So the question we wanted to answer was, well, how important is this historical information? So we chose pregnancy care because there are aspects of it which suggest that historical information is relatively important for that type of care. So if we didn't find it here, it would be hard to find it in other types of care. So to get at that, we partnered with our local hospital, and we deployed surveys where we asked providers directly after each patient encounter whether certain types of high-value clinical information were available to them during that visit. And when we were on the inpatient unit, we asked about data from the outpatient prenatal record. When we were in the OBGYN offices, we asked about data from any visits to the inpatient unit. So I'll talk a little bit more about that in a second, but essentially in pregnancy care, patients go between these two care settings frequently towards the end of their pregnancy. Now, in order to estimate a model to look at the impact of information on outcomes, you need to have variability in information. And you don't necessarily want to use, there's a lot of that variability across patients is due to their circumstances. And the worry there is that some of that variability is endogenous to outcomes, and some of it is not. So our strategy was to kind of control away, hopefully, the variability that's endogenous, it's related to patient illness severity, and to make use of the fact that data availability would be changing because this network was implementing a EHR system and integrating it over a multi-year period to allow information flow across care settings. So that was the identification strategy. And so after we collected these data on information availability, we correlated it with health outcomes that we got from billing data or from chart review. Now, the second objective of the study was to, assuming that the information had value, to look at how well the EHR system provided that information. So if there were limitations there, what were they? And so to look at that, we took a different approach. We interviewed 75 physicians, nurse midwives, nurse practitioners, non-clinical staff over this same 4.5-year period and asked them about their experience with the system. So we're using qualitative methods to get at that. Okay, so here's a schematic that will allow me to describe pregnancy care and the way the data flows in the hospital. So typically, pregnancy is managed in the outpatient setting, and then when women feel that they're ready to deliver or they're experiencing some kind of acute problem, they'll go to the hospital and they'll be received at the inpatient triage unit on the labor and delivery floor. So that's like an emergency room for pregnancy is one way of thinking about it. Now, they'll be evaluated there. And if they are ready to deliver, they'll be admitted formally to the labor and delivery unit, which is right next. It's actually on the same floor, but it's just down the hall. If they're not, they'll be discharged, evaluated and discharged, and they'll almost always follow up with their outpatient physician within the next few days or so. And most women will go to triage at least once before they're ready to deliver. Now, the data flow in this system, well, there are separate EHRs that were subsequently integrated. They're same vendor for each system, but the initial part of the integration was that information from the outpatient offices would begin to flow to the triage unit. So before that happened, the process was that paper records were couried, sent over by courier about every 2 weeks, or if the patient got there and there was no information, they would call the office if it was open or have information faxed. So the first part of the process was to get the information flowing in that direction. And then subsequently, the operability was enabled to allow patients or physicians in the outpatient practices to get information about triage visits. First, just a summary of that information, and then some discrete data elements were transmitted, which would populate the EMR interface. Okay. So we conducted 3 rounds of surveys in both those locations In either case, our first round of survey was sort of pre-interoperability, so however they got information under the old process, that's what we were capturing, and then the subsequent 2 rounds of surveys were after that data integration had been either fully or partially achieved. And then the interviews that we conducted were also around the same time points. Okay, so the first thing was just to look at, this is data that's flowing from the offices to triage. So did the flow of information improve over this time period, during which the EHR was being implemented? And the answer is yes. So these are the clinical data elements that we tracked that we were told were most important for pregnancy care. We have cervical exam results, blood pressure, problem list, Group B strep, non-stress test results, prior uterine incision types, and tubal sterilization requests for Medicaid patients. So the only measure that doesn't improve over time is the last one, and then that requires a little bit of explanation because it's not a clinical measure. So the reason we looked at that is because for a Medicaid patient to have a tubal ligation done immediately after the delivery, there has to be a consent form that's signed at least 30 days prior. So providers have to verify that that consent was done at least 30 days in advance, which means they need to have that information available to them right before the delivery. In the past, when that information was available, they spent a lot of time trying to get it, because if they didn't have it, they would have to bring the patient back in for a subsequent visit to perform that procedure, which is very costly for both the patient and the physician. Okay, so we do see overall that the information flow improved. Okay, so how do we measure the impact of the changes in information on outcomes? Well, most of our outcomes are discrete, so we, for the triage models, we focused on birth outcomes. So we look at obstetric trauma, and we also looked at an index of adverse outcomes. It's a weighted score developed by OBGYN physicians, and that's it's a continuous measure. So we modeled it using a 2-part model of whether the score was greater than 0, and then the log of the score. But we never put the 2 parts together. We just look at them separately. So we use linear probability models that include physician fixed effects. We also looked at 2 measures of clinical process. So, if we do find an impact on outcomes, we would expect that it's because clinical process is changing as a result of the information. So we looked at labor inductions and C-sections. For the models that use data from the offices, so whether the office data that's reflecting their knowledge of triage visits, we looked at maybe longer term indicators of pregnancy care, so whether there was a preterm birth or low birth weight. So the nice thing about these data are that we have lots of data on patient risk and illness severity. So we use that to control for lots of things, including we calculate DCG HCC risk scores for each patient. And we have a lot of additional information that we controlled for that. All right, so let's just go through the results. This is obstetric trauma, and this is basically looking at the impact of information from the outpatient setting on, that's available to physicians on triage and whether that impacted obstetric trauma. And so we find, I guess I should mention, we did this 2 different ways. So our parsimonious model is we did the regression just on that one clinical data element, so every row is a separate regression. And then the saturated model is we basically put all of the indicators in there and ran one regression, so that column is one regression. And we did that just because there's a lot of collinearity in data availability across measures. Okay, so we found that there was an impact of non-stress test information and the tubal sterilization request. Everything else in the parsimonious model that has a negative sign, meaning if that information was available, is associated with better outcomes, lower rates of obstetric trauma, but they're not precisely estimated. So, when we presented this to physicians there, the one good thing is they were bobbing their heads, which meant that, to them, if they had to choose one thing they thought was most important from a historical perspective in terms of the patient's record, non-stress test was it. So that made sense. A little bit of a question as to why we didn't find an impact on the other items, and there's various explanations. Blood pressure, for example, we know is very important because it tells us whether the patient is at risk of preeclampsia or eclampsia. And one explanation is that the patient is more aware themselves of that information. So you didn't need to have the patient records. The patient would tell you that, but patients don't know how to interpret a non-stress test. So that's one explanation. And in terms of tubal sterilization requests, our interpretation for that effect is that in the past, when that information wasn't there, providers spent a lot of time trying to get it, and that may have distracted them from providing care. But these effects are pretty large, so there's 7 percentage points, which is just almost as big as the baseline average rate of obstetric trauma. Okay, so for weighted adverse outcomes score, we again see the tubal sterilization requests, and then we have some other information, blood pressure, and the problem list showing up. The problem list in particular, I think, is it's not statistically significant at the 10% level in the saturated model, but very close to that, and the point estimate is similar. So I think that's probably a legitimate effect there. The blood pressure magnitude drops a little bit more. Okay, so in terms of process measures, more things show up. I forgot to highlight the non-stress test one on the left, I see. But more things affect clinical process, which is to be expected because changes in clinical process won't always result in changes in adverse outcomes. But there's an interesting trend, and that's that more data seems to increase rates of induction and decrease rates of C-sections. And so if you think about these two measures in the medical literature, the conclusion is these things should be avoided except when they shouldn't be. So in general, these rates, we try to keep them low. But labor induction is essentially a response to the fact that the fetus or the mother is at risk because something happened. And so our hypothesis here is that when they have more information, they're better able to identify risks on triage. And so they're actually, that information is allowing them to put the patient into a higher risk category, which merits induction. Now, the reason it's different with C-sections is that almost all planned C-sections are directly admitted to the hospital, so they don't come through triage. And what we're really capturing here is emergency C-sections, that those are happening less frequently because they have more information to manage the case. Okay, so going on, looking at the other side of our data. So this is information from triage flowing back to the OBGYN offices. What we see is that we do find some effects on low birth weight. One challenge with these models is they have small sample because we first ask the physicians, did the patient visit triage? Or, yes, no, or you don't know. And then we ask them, well, if they did visit triage, was this data available? So, most patients didn't visit triage before they kind of came back for the visit. Or not, a lot of them didn't. And, I guess a lot of them did visit triage, but the physician didn't know. So that's a factor. So we ran these, for doctors that knew the patient visited triage and those that didn't know, and the results are basically similar. So I'm kind of coming to the end of my time, but I'm going to co-opt my discussant's time. It's a prerogative of the chair. In any case, what we found was that information on new diagnoses and cervical exam results from triage were associated with improvements in birth weight. And the only thing that changed when we ran this on the larger sample of physicians who didn't know whether the patient visited triage was that laboratory work became important, which I think was more of a precision issue. Okay, so another thing we did was we took our survey data, and then we took data from the EHR system directly, and we essentially audited our survey data. And we just did that with our post-period survey rounds, of course. And there's 4 possibilities. You know, the data is in the survey, it's in the EHR. That would be what we would like to see the most of. The data is in the EHR but not the survey. And if that's true, it suggests a problem maybe with the user interface, that the physicians couldn't find the data in the system. The other possibility is it's in the survey but not in the EHR. And that means that they must have gotten that information some other way than through the EHR system. And lastly, it could just not be in either system. So, very interesting result we found was that the information was a lot of times on triage in the survey, but not coming through the EHR. So, when we looked in, so we actually drew on our qualitative interviews to figure out what was going on there, and that is the result of a workaround. So, instead of getting the information through the interfaced system, they developed a workaround where they installed the outpatient terminals directly in the hospital. So physicians or providers could, leave the inpatient EHR, go to another computer, and access the patient's record directly. So that's the outpatient record right there. And they preferred doing that to getting it through the interface system. And one of the reasons why was basically technical issues. So a lot of times the data was not flowing correctly, like some patient data was missing. And it was missing for like entire patients were missing from the interface system. And even when the data was there, they couldn't easily find it in the interface. Now, on the outpatient side, you don't have that issue. They never had the terminals installed, in the offices. But we do find that a lot of times the data was in the EHR, but they said they didn't have it available to them, which suggests a problem with the user interface. All right, so to conclude here, I'm just going to go to our interviews and provide some context for these results. So, the first major theme in the interviews was technical problems with the user interface. Providers could not find the data in the system. And so here's a quote from a physician. She just says, "So now I'm a data miner. I spend a lot of time data mining and wasting time trying to find data that's there." In another study we did, we looked at productivity, and we identified the wasting time effect ends up being pretty significant, in the early stages of the implementation. Another important theme that we uncovered was trust in the data. So because physicians and providers had gotten burned trying to find this data, they didn't trust it. Even though it was there, they didn't necessarily believe it was accurate. Like a lot of physicians will tell you that I want to see the lab result. I want to see the lab's stamp on it. They wouldn't believe the data. And so here's one from a physician. "I don't trust anything or anyone or anything automatically flowing." So I think we caught that person on a bad day, but it gives you an idea of how acute this issue can be in terms of getting providers on board with using these systems. At the same time, a lot of physicians recognize the value of the information that they didn't have before. So, here's one. Basically, it's kind of like one of those things where we didn't have the information. In that case, you can still look after the patient, but do I think the quality of care would be the same? No. It's because it's kind of like working in the dark. When you have, the complete picture there, the context is very different. Okay, so that's just, that's indicative of the fact that for pregnancy care, having that historical series of information does matter. Okay, so just to summarize, we do find greater availability of clinical information is associated with better outcomes. It does change care processes. That EHRs can facilitate that. Overall, data availability did improve. But, there's a lot of issues, a lot of technical issues, and just work process redesign that needs to occur. And then, final just limitation is that these data were not generated from any type of experimental setting. These are not causal effects. They're associations. We just do our best to control for confounders like, baseline patient risk. Okay, so that's the end of the presentations, and we'll take questions from the floor.
Hi, Jenna. My name is Gerald Delisi. Great topic with regards to the patient-centered medical home, and great finding as well. Now, the patient-centered medical home is just one of 5 transformation model, I believe. A patient, a primary care facility can actually be involved in more than one patient care model. Now, did you consider the fact some of those facilities could be, participating in more than one transformation model? And how did you isolate for just the patient-centered medical home, so that to make sure that you are actually analyzing the correct variable?
Yeah, so unfortunately we don't have data on other programs that the practices are likely participating in. It's a really great point and something that unfortunately we just can't control for.
Thank you.
Yeah, Lorenz?
I have a question for you, since I'm right here. Did you measure total time spent for the entire visit? Because I would wonder, you know, if you have your smartphone with you, you just post on Facebook while you're waiting, but then the difficult time is when you see the physician. So,
Yeah.
And you would want to minimize the total time spent, probably.
Yeah, exactly. Actually, we do measure all the waiting time, all the time flowing in the clinic. So, if you still remember my chart, do you think that?
Yeah, I remember it.
Yeah. So, actually, the lower part of the lower part of the chart is the time spent within the exam room, and the upper part of the chart is the time spent in the outside of the exam rooms. Yeah, so I do have all the information. So that is how I use the simulation model to evaluate different scheduling policies. And by doing by using the total waiting time in the entire clinic, so that total waiting time in the entire clinic is my metric for my simulation models.
I mean, I was just wondering, you know, the objective function could be to minimize total time, not just waiting time, just total time you're spending at the clinic.
I mean, I see you mean the throughput in the entire clinic.
Right.
Total waiting, I see.
The difference
Okay.
between getting in and getting out.
Yep, okay, thank you very much.
Maybe one more question. Over here, Gordon.
Thank you very much. Actually, I can take this opportunity to ask 2 questions.
All right.
So, one question is actually to you. So you found that you know, with the availability of data, then there's a reduction in the C-section, which is fascinating. Can you elaborate a bit more? What's the mechanism behind it?
Yeah. So with C-sections, you know, there's 2 types. There's planned and emergency C-sections, and you know, a lot of times C-sections are done either at patient preference or to manage the risk that's happening during the pregnancy. But in either case, you know, typically the decision is made at the offices. So, you know, when we only find that effect when we look at information that's going from the offices to triage. So most of those planned C-sections, like, we're not really picking up an effect on those planned C-sections because they're usually directly admitted. They don't even go through triage. And even if they do go through triage, that decision's been made. I think that, you know, you could almost treat that as a reflection of adverse events. We're picking up emergency C-sections. So the idea, I think, or the thought I have is that because more information is available and they're better able to manage that case, they end up preventing an emergency C-section. So it's almost like, you know, we're treating it as a process measure. I could almost interpret it as another adverse outcomes measure. Yeah. Other question?
Yeah, my question to Yi-Chen is that, you know, as Lawrence, I remember all your slides. So in one of the slides, you mentioned that there's a limitation of RFID data, which is missing data. In theory, the RFID will enable more complete records for all the activities. Why, you know, is there a limitation of missing data there?
Thank you very much. There are basically there are maybe 2 reasons. The first one is that the main reason is when the tags are out of the range of the monitors, then we cannot have the complete data on the visit. So the actual situation, one example is that the patient may hide their tags somewhere under their coat or under their purse. In this case, I cannot get the information. Or if sometimes the patient or patient or the doctor, if they go out of the range of my monitors, then I don't know where they are going. There will be a missing chunk of the flow in between. So that is the missing data. That's why originally I have 389 visits, but I can only have 204 visits, complete visits for analysis.